Okay. Hello, everybody, and welcome. My name is Dr. Lori Tucker, and I'm pleased to be the moderator of this very special session today from Cassie and Friends about CRMO. I'm so delighted to welcome you all to this very special session. It's the first one that we've had focused on this disease. Our Cassie and Friends virtual education sessions address the vision of Cassie and Friends to transform the lives of families affected by arthritis and other rheumatic conditions. We wouldn't be able to bring these sessions to you without a group of very generous sponsors who are listed on the slide here, including the Arthritis Society, Nicola Wealth Management, AbbVie, Amgen, and Sobi. We're so fortunate to have the support of these organizations to bring you all this virtual education programming. Next slide. If this is your first Cassie and Friends session, I want to let you know that Cassie and Friends has a wonderful online virtual education library, which is free to view. Some of these previous sessions may be relevant to you, some of you who are here today, so take a look when you have the chance. The session today is going to be recorded and available on the library soon, so you'll be able to share it with family members and friends who aren't able to attend today. Next slide. Do visit the Cassie and Friends website for additional resources and information on various rheumatic diseases, medications, and other important topics such as nutrition, physical activity, mental health, and school. Next slide. It's amazing. We have 126 attendees who registered for this session today. The map here shows you where you all are from, over 75 cities and towns in 15 countries around the world. It's amazing to me. We have other ways through Cassie and Friends for you to be connected to other parents through the Juvenile Arthritis Canada Facebook group. This group does include families of children with all rheumatic diseases, so you can look online to join this group and stay connected with other parents. Next slide. We'll have a good amount of time at the end of the presentations for questions and answers. Please use the question and answer button below for questions, and we'll try to get to as many of them as we can. 2 quick housekeeping notes. For one, attendee mics are going to be muted. And number 2, if you have technical difficulties, you can use the dial-in number in the registration email you received or the reminder email you received today. So let's get started. Next slide. I'm really delighted to introduce to you our family speaker today, Sheila Grant. Sheila is the mother of 2 young men with CRMO who will be sharing her family's experience. I first met Sheila and her son Nolan in 2016 when Nolan was 8 years old. Since that time, Nolan's brother also developed CRMO, and together as a family, they've navigated the effects of this disease, treatments, and all the normal teenager issues too. Thank you, Sheila, so much for coming today to share your family's story with CRMO. I'm sure many of you listening will recognize things that are relevant for your child and family as well. Sheila, over to you.
Hi, Lori. It's Brittany here from Cassie and Friends. Unfortunately, Sheila's having some pretty extreme technical difficulties today, so I think let's start with Dr. Ferguson, and then when Sheila gets on the line and Dr. Ferguson's over, we'll go back to her.
Great idea. Okay, so I have the great pleasure of introducing Dr. Polly Ferguson. Dr. Ferguson is the Director of Pediatric Rheumatology, Allergy and Immunology, the Marjorie K. Lamb Professor of Pediatrics, and the Executive Vice Chair of the Department of Pediatrics at the University of Iowa Carver College of Medicine. She received her medical degree from University of Iowa Carver Medical School of Medicine and completed training at University of Virginia School of Medicine and returned back to University of Iowa to continue her stellar career. I've known Polly for a number of years, maybe more than we'd like to admit. Dr. Ferguson is well recognized as an international expert in the area of CRMO. I have such admiration for her research achievements as Polly began to study CRMO from a basic research perspective when very little was understood about this disease. Her research is focused on finding the genetic and immunologic basis of CRMO and other autoinflammatory diseases. In addition to her many publications and research grants, she has been a tireless collaborator internationally to advance research in CRMO and to include affected patients and parents to increase awareness of these diseases and how they affect children and families. We are so fortunate that she's taken time out to speak to us today, and I welcome her to our webinar.
Okay, I don't think I screen shared properly. Let's try it again. Oh, it says I am screen sharing. There, can you see it?
That looks great.
Okay, woohoo! We got through one technical barrier. Hi, everybody. So I'm Polly Ferguson, and I was really very excited to be able to talk to you all. And I'm trying out a new talk for everyone. Since this is patient and family centered, I thought, how could I do this most effectively to communicate to everyone who's there, from the younger kids who want to know what's the matter to them, to the parents, and to some of those out there who want to know even more scientific details. So I'm hoping that this approach will kind of hit everything, and at least everybody will get something. So we're going to start with a little immunology lesson. And this is what I do in clinic. We have a whiteboard. And so I take and get a marker and start talking about what's going on in the bone. So chronic recurrent multifocal osteomyelitis or chronic non-bacterial osteomyelitis, the main thing is osteomyelitis. So you have inflammation in the bones. And so what you have to know first is, like, what does the bone normally do? And so the bone is constantly being made and taken away. And it's because of these bone buddies. So I've drawn Bob, like Bob the Builder. I don't know if you all have Bob the Builder, a cartoon, but and so Bob is the osteoblast. So he's building bone. And at the same time, we have this little Pac-Man guy who eats bone. So he's always eating, and he's an osteoclast. And normally the osteoclasts are happy, and he and Bob get together very well, and they have a good relationship. But then sometimes the osteoclasts get super angry, and that's what happens in CRMO, and it's because of immune activation. And so we get this very out of balance bone metabolism going on, where the bone eating cells that the Pac-Man guy is eating away, and the builder can't keep up. And so you get areas of the bone that actually are taken away, or an osteolytic lesion, if you look at it on an X-ray. So this is due to immune activation. And so the immune system is designed to keep out foreign invaders, bad actors like viruses, bacteria, and fungi that can make us all sick. So you can think of our immune system as a bunch of soldiers fighting off invaders. The problem in CRMO is that they're fighting, but there really isn't any evidence that we can find that there's an invader or danger. So no infection, at least at the time that people are getting biopsied. So yet the cells of our immune system are turned on, and they're releasing proteins that are making inflammation. And so they're like signalers that keep telling the soldiers, there's danger, fight harder. And so it makes inflammation. And so some people will ask me, well, what does inflammation mean? And so it's when any part of our body becomes reddened, swollen, hot, and usually painful, especially in reaction to injury or infection. So that's the most common reason to have inflammation. And so we have, in this disease, osteomyelitis, or inflammation in the bone. So here's our Pac-Man guy, and he's angry. So the immune system, there's lots of different cells. And so we wanted to know, well, what cells are involved? And the evidence points to the old part of our immune system as being probably the biggest culprit. So the new part is like B cells and T cells, and they make antibodies, and they're kind of become very smart about what they're trying to protect. Whereas these guys over here are our first line of defense, and they just bluntly, when they see a danger signal, it can be a danger signal that's common to lots of different bacteria, not specific, and they turn on and they help to get rid of it. So why are the osteoclasts so angry in CRMO? And so there's evidence based on looking at blood and cells from people with CRMO that there's all of these molecules that can make the osteoclast angry. And for CRMO, IL-1 can do this, especially in what we found, these rare genetic disorders that I study, and tumor necrosis factor. These again are those proteins that are being signaled to the soldiers to fight. So they're hitting this Pac-Man guy, and he's just all angry and starts to eat and eat. And then it makes him more activated, and you get more cell production, and it's a vicious cycle. So cytokines are these proteins that we're talking about. So tumor necrosis factor, or TNF, interleukin-6 or IL-6, interleukin-1 or IL-1. And these are examples of three of the best known pro-inflammatory cytokines. So pro-inflammatory makes that Pac-Man guy angry, okay? He's gonna activate the immune system. So they're for inflammation. Whereas the anti-inflammatory ones like IL-10, IL-19, calm this guy down and make him happy again. So in CRMO, there's like an out of balance. So instead of having a balance of pro and anti-inflammatory proteins, it gets to the point where there's too many pro-inflammatory proteins around, and you get inflammation. So there's some evidence that this can be due to gene regulation. And so Christian Hedrick's group now he's in the UK, has looked and found some epigenetic changes. And we'll talk a little bit, probably not get into epigenetics because it's complicated, but bottom line is there can be changes that change how much of one of these proteins is made by our genes. And this is another form of gene regulation. So that can happen with some of the other well-known proteins that are, so the genes are, methylation's reduced in some of these pro-inflammatory or inflammatory protein pathway genes, and you'd get more inflammation. So more of the angry Pac-Man. So here's my little drawing, why so angry. And this I took from this paper here, and they're really looking at osteoclastogenesis and bone resorption in rheumatoid arthritis. But the basics of bone resorption in CRMO are pretty similar. So here's the osteoclast, that's the Pac-Man guy who's eating and causing damage. And all these different proteins can come in to make it differentiate, turn into this angry guy, increase survival so they last longer, or make them more activated. And so it's an interplay with the immune system and the osteoclast that's causing inflammation. I will also tell you that the osteoclast is an immune system cell. So he is also part of this process. So I'm going to give you one example because we're going to talk about the role of interleukin-1 first in this disease, because that's what we have the best basic knowledge for. And so this is the Pac-Man guy here, his little face, he's angry, he's very activated. And that can happen when there's too much interleukin-1. And so in this process, a bacteria, a virus, or something can get you started. You make too much interleukin-1, that can cause fevers, but it can also activate lots of immune system cells to make even more. And it just, then it feeds back and keeps this vicious cycle of keeping them all excited. And this is a little protein itself, and then this is a receptor. So we have receptors on our cells for lots of different proteins, and this one's the interleukin-1 receptor. So if interleukin-1 binds to it, then it sends a signal to be activated. So it's like the gas is on and the car is going go, go, go. So our body needs to be able to shut this off. And so we have natural brakes in the system. And one of the proteins we make is called the interleukin-1 receptor antagonist. So it gets into that interleukin-1 receptor and blocks it so that this guy can't go over here and bind. And if you can't signal through this receptor, then you're happy. And so here, this is a situation where the brake has been put on to try to stop the inflammation and go back to the happy place that we were prior to it starting. So I'm also going to talk about genes, genes like DNA, encoded genes, and not like blue genes, which I have on right now. So genes are kind of genes and how proteins are made. It's kind of like reading. So it's like an alphabet. So there's these letters and they encode something like ATG says to start and TGA says to stop. And there's other combinations of letters that tell you to make different building blocks for proteins. And so the interleukin-1 gene would have a specific kind of alphabet or spelling that would make that whole big long gene come out to be one that could make IL-1. So we have genetic diseases, and there are things that are genetic that are not diseases. There's everything about our person is encoded by something in the DNA that can be influenced by environment. So our genes, there's lots of them, about 30,000. But then there's a whole bunch of other stuff that we don't really know what it does. So there's about 3 billion letter pairs that we're made up of. And humans, like each of us, are really, really alike. When it comes down to all of these genes and genomes, we share 99+% of our genes are similar. So most of our genes are the same, but some genes are different. And sometimes that just makes you have blue eyes, like I have blue eyes, or it can make you make too much inflammation, or not have the right tools to shut off inflammation. So genes can code pro and anti-inflammatory proteins. And so what genes we have are important in our predisposition to getting inflammation. So eye color, it shouldn't say changes because you're usually born with just one. So your eye color is definitely determined by genetics. And there's some main eye color genes, but there's lots of others that have smaller influences. But whether your eyes are blue or brown is determined by your genes. And most people kind of have a sense for that. Whether you're got long legs or short legs, that ultimately is determined by genes too, but not in a way that's as easy as blue or brown eyes. So some changes in genes can cause you to just have a certain eye color, but others can have really negative consequences. And that's what we would call a genetic disease. So there's 2 types of things that we're going to talk about. Mostly we're going to talk about recessive diseases. And so you can think of like your mom and dad each gave you a copy of your genes, except for we won't talk about the sex chromosomes because they're different. So you get one from your mom and one from your dad. And if both copies are bad, then you can have a recessive disorder. If just one copy is bad and the other one's good, sometimes you still can have a genetic disease, and it's called dominant. Don't worry too much about that. We'll have a little bit more about it later when we talk about mice and people, but it's not that important to know. So we know that CRMO can be caused by gene mutations, and I'm going to talk about that and what that tells us about what's going on. So this is some of the evidence that there's genetics to CRMO. And so one of the terms that you'll hear sometimes is auto-inflammatory bone disease. And that just means that we think the old part of the immune system is doing the work, like I talked to you about earlier. So the evidence that there's genetics involved is that there's affected siblings, like Sheila's kiddos. Sometimes there's a parent-child pair, like I saw in the chat. Somebody said, I think that mom had it in one of their children. So those kind of things suggest that there's genetics to things. And in our group of patients we follow here, for half of the time, we'll get a family history of either a first or second degree relative. That would be like a parent or an aunt or a grandparent. That half of the time, there'll be somebody in that family that's closely related that either has psoriasis, inflammatory bowel disease like Crohn's disease, or arthritis. I'm going to tell you about single gene models of the disease that we found, genes that when they're mutated or changed in a bad way cause disease. There's animal models, so animals can get CRMO. There's several mouse models. This is the CMO mouse. We study this mouse a lot. And my colleagues at the University of California in Davis have studied dogs that get an equivalent disease, and Weimaraners are more likely to get it. It's called hypertrophic osteodystrophy, but it looks very much like human CRMO. There are humans that get single gene defects that can cause CRMO. One is part of DIRA, deficiency of the interleukin-1 receptor antagonist. It's due to mutations in IL-1RN. There's Majeed syndrome that's due to mutations in lipin-2. And then there's rare cases of typical CRMO that we found some evidence that genetics can play a role. But by and large, we do not have the explanation genetically for virtually all of CRMO. I would say this might make up 1% that we understand. So lots of work to do. So I'll just tell you the stories of how we found these genes that we do know can cause bone inflammation. So this is the story of the deficiency of the interleukin-1 receptor antagonist. And these are the key people involved, particularly Dr. Dancy. He is a Canadian pediatric rheumatologist who recognized one of the first patients who had this. And it was a little baby who was very, very sick and had lots of bone inflammation. So if you're not used to looking at x-rays, which most of you aren't, there's problems at the ends of the collarbones and the ribs and in the bones of the femurs, very much abnormal. And the babies would also get pustules, which are, they didn't like, probably the most common thing that we think of was a kind of a pustule was a zit. But so these are little tiny, pus-filled lesions that can be just a few or lots, and can be pretty extensive on the body of these babies. So he thought, this is something that I've never seen before. It looked somewhat like some diseases we've seen in pediatric rheumatology before that we know already are due to problems with too much interleukin-1. So I showed you that little cartoon before. If you have too much interleukin-1, the gas is on, you make inflammation like crazy. And that's what's going on in these babies. So along with the folks at the NIH, Dr. Golbach-Mansky, Dr. Aksentievich, and Dr. Masters, I think Seth is now back in Australia, found the gene for this by studying some families that I had DNA on, that the NIH had DNA on, that Dr. Dancy told us about, the first child. And so we were able to find that all of these babies have 2 bad copies of the gene that encodes or makes the break to the interleukin-1 pathway. So I'm going to show you that little image again to remind you that we all have these little breaks in the system, and this baby can't make the break protein. And so it just gets inflammation that doesn't stop. So here's that little image again. So the babies that have this defect, they can't make this protein right here. So they can't shut this off, and it just keeps going and going and going. So you get bone inflammation, skin inflammation, and really inflammation in lots of different organs. And those babies, if they didn't get recognized, most of them died from inflammation. So very, very severe disease, not like what most people have CRMO experience. So happy day was that it just so happened that the pharmaceutical industry had made a drug treatment for inflammation, including they tried it in rheumatoid arthritis, which was to make that protein that is the brake to the system. So these babies were able then to be treated with the very protein that they were missing. And so when you give them back the protein that they don't make, now they have the brake. And before, very unhappy, just inflamed, feeling miserable with bone lesions. And then about a week later, their skin is looking much better. And this is several months later. It takes a while longer for bones to heal. But anyway, it was that we already had this particular protein available to us. And so this disease is now easy to treat, although it's still not fun to get the therapy, which are shots. So this is the second story. This is Majid syndrome. And this was Hassan Majid and Hatem El-Shanti, both physicians from Jordan. Dr. El-Shanti is back here at the University of Iowa as our head of medical genetics. They recognized, well, Dr. Majid, I should say, recognized some families that had really early onset CRMO. So most kids get CRMO around the age of 9. So 4 to 11 is probably collects a lot of the patients. And these patients develop it at 2. So, and they saw that there were brothers and sisters that had this disease in the same family, but their parents were healthy. And so when that happens, we think that it might be autosomal recessive, needing 2 bad copies of that gene to get the disease. And some of them had this funny anemia. Well, actually, most of them have this unusual anemia, and a few had skin inflammation. But here is a patient who was bedridden from so much pain and inflammation. And this was before we had the good medications that we have today to offer that child. And so they became bedridden. And then this is an old school way of looking at inflammation in the bones. So this is a bone scan, and they've got inflammation in their heel, both ankles, around the knees. And then this is their bone marrow. And these cells here have 2, the purple is called a nuclei, and the light purple is the cytoplasm. And so you're supposed to just have 1 nucleus in each cell, but these guys have 2 or 3. And so the body sees that as abnormal, and they pull it out of the system, and then you end up with not enough red blood cells and you're anemic. Sometimes they have to have red blood cell transfusions. So we found, Dr. El-Shanti and I, that this was due to mutations in this gene called lipin-2. This is super rare. So there's only, I think, 24 families, 24 patients from 11 families. And this codes a protein that is really important in fat metabolism. So it's an enzyme. It converts phosphatidic acid to diacylglycerol. And that happens to be a really critical step in lipid metabolism. And interestingly, you wouldn't think that changing fat metabolism would change the inflammation system, but it does. So too much interleukin-1 is made. And we really first found that out by trying to treat this disease. So this is 2 boys who had Majid syndrome. So they both had early onset CRMO and anemia. They were diagnosed with Majid syndrome. They have a genetic mutation, so we know genetically that they have it. And so this is a marker of inflammation, a sedimentation rate, which I'm sure a lot of you all have had, or your children have had drawn if they have CRMO. And they had really high sed rates in the 100 ranges. And so they got treated with steroids and got them kind of better controlled. They tried a TNF inhibitor here, and they got worse. And so then they tried to block the interleukin-1 pathway, and they got markedly better. So they were using one of the interleukin-1 blockers that's a daily shot, and the mom had 2 boys and she just couldn't take it anymore. And so they stopped the medicine and they both got sicker. And then they started at one that blocks interleukin-1 beta that you only have to give once a month. And so she was able to make that work with her life and her family, and was able to get each of the boys treated. And if they blocked interleukin-1 beta, they both got better. So here their marker of inflammation in their blood, their sedimentation rate is now normal. This is the inflammation, is this white part in the bones. This is what it looks like on MRI. And these are stir sequences. And so the abnormal bone is bright white. So you can see that there in their, from their knee bones down to their ankles. And 3 months after treatment with the interleukin-1 beta blocker, their bones are better. And this has been repeated in multiple other families now. So this is for the science nerds out there. The rest of you, it's just one slide to suffer through. What they found is that our group and others have been looking at this in multiple different ways, but essentially this is the protein that's missing. And when it's missing, you don't have enough cholesterol in your cells. And so it makes one of the receptors on the cell not work very well. And when it doesn't work very well, it activates part of our immune system that makes interleukin-1 beta. It's called an inflammasome. And so if you take cells that don't have lipin-2 or lpin-2 and feed them back extra cholesterol, this receptor starts to work again. And then we get down regulation of this inflammasome and less IL-1 beta produced, and then they get better. So another approach we're using is whole exome sequencing. So you can take everyone's DNA that has CRMO, and what we've done is tried to get study families that have multiple affected members, so affected SIB pairs with unaffected parents, or an individual CRMO plus a relative with psoriasis or Crohn's disease, or a parent whose child has it, or kids who get sick super easy. Excuse me, not super easy, but super early. So very young kiddos. And we sequence their DNA for all of the parts that of the genome that encode for a protein. So we're just looking at this very small bit of the genome. And then we look, do people have new mutations? And we have been able to identify some additional genes, one in FBLIM1, one in FGR, and then a child who had a RAG1 deficiency, which is an immune deficiency. So that child had some other unusual features, but also had CRMO a part of it. And so this was done in collaboration with Allison Cox, Alex Basuk, who's my longtime collaborator and new boss, Ron Laxer, who is just a fantastic person and a fantastic Canadian pediatric rheumatologist, and Colin McCurley, who runs the transgenic mouse facility at the University of Toronto and Sick Kids. So here's a mouse. So I told you that now those are two human diseases that are caused by gene mutations or a change in that letter. And then this is a mouse model that also is due to mutations in that in a gene that encodes something called PSTPIP2. And this is also recessive. You need 2 bad copies of it to get the disease. And this is normal bone. This is what their feet look like. They're supposed to have little skinny little toes. And so these are all inflamed, very enlarged. This is what bone looks like if you look at normal bone in a mouse. And this is what the bones in here look like. So lots of immune system cells. They're chewing away. You can kind of see this eaten up stuff, and you can see cells eating away. And I'll show you some osteoclasts in a minute. This can affect the skin and the cartilage in the ear in these mice. And then here's what with the special stain called a trap stain. This is what the bone looks like in those mice that have osteomyelitis. So this red stains osteoclasts. This is what they normally look like. So this is WT stands for wild type, which just means a normal mouse, not without a mutation. So when this mouse has 2 mutations in the PST-PIP2 gene, it gets super angry. These are huge osteoclasts, and they're all chewing away at bone. And so they're making a spot in the bone where there is no longer a solid bone. And if you did an X-ray, it would look like a hole. So this one we found, I'll show you, is due to too much interleukin-1 to make these osteoclasts angry. And we first came upon that by just taking bone and seeing what was inside of it. And so we found there was too much IL-1, more than the other things, including TNF. And so what we did was we said, well, hey, let's see if we block the ability to signal through that receptor. So if we could do something like this, either give them the medication that would block the receptor, or even more straightforward is just get rid of the receptor. So you can make a mouse that does not have this receptor at all, okay? So we made a mouse that doesn't have that receptor at all. And so there can be tons of IL-1 circulating around, but it can't send a signal. And so the bone is back to being happy. So this disease in mice is definitely interleukin-1 driven. And so this just shows you, if you look at a bunch of mice over time, these are the number of days, and this is disease-free survival. So this is 100% of normal mice would live to 170 or 180 days. The CMO mice, it's not really live because they just wouldn't get disease. They all live. The CMO mouse gets bone inflammation starting around 30 days, and by 60 days, all of them have bone inflammation. And if you have one copy of the interleukin-1 receptor, they get disease too. It's a little bit protective to have one that's missing and only have one. But if you don't have the receptor at all, you're back here to where a normal mouse is. You just don't get disease. So here you have one copy, so you can signal through, you get lots of damage. Here's a normal bone when you don't have the receptor at all. Here's the swollen paws, and here's normal paws, and here's a good looking tail, and here's one that's got damage in it. And you can see here inflammation in the ones that can signal through that receptor, and if you block it completely, they're normal. So really great evidence that interleukin-1 is required. Now this, I think, is one of the most intriguing things that has been found in the field. So another group was looking at their mice and decided to change diets on the mice. So they went from feeding a low-fat diet. So this is a normal mouse, normal genetics, happy foot. This is a mouse fed a low-fat diet that has the gene mutations on both chromosomes. So it gets inflamed foot. If you feed that mouse instead of a low-fat diet, you give it a high-fat diet, it's completely protected. And this is pretty impressive. This is a regular mouse. Usually we feed low-fat diet. So a regular mouse on a low-fat diet, the CMO mouse on a low-fat diet, lots and lots of bone destruction. The CMO mouse on a high-fat diet, normal bones. Use caution. Mice are not humans. We don't know yet what this means for human disease. I will tell you that there is not a patient out there that I have found yet that has mutations in this PST-PIP2 gene that has CRMO. So there's no human equivalent to this mouse. So we've got to use a lot of caution. So why aren't we using interleukin-1 inhibitors? Since all of this basic science data that I've spent the last 15 to 20 years doing show that interleukin-1 seems super important. So, well, the single gene models of the human, mice, and dogs, super rare. They don't make up most of the disease. Most people have sporadic disease, or we don't know the genetics for it, although we're looking. And I can tell you that it's complicated. There is definitely no single gene or 5 genes that are responsible at this point that we can find based on how we're looking. So based on the use in clinic over decades, started well before I started studying this disease, we've learned that non-steroidal anti-inflammatory drugs like naproxen or ibuprofen. They have different names depending on what country you live in. They have broad anti-inflammatory effects that help many. So a lot of people only have to take a non-steroidal anti-inflammatory and do much better. We know that steroids, they have really strong anti-inflammatory effects, but they have lots of side effects. They're not a good long-term solution. I tend to try my best not to use them because I just think the side effects are so unpleasant for the kids that I try my best to get around it. So what do you do when the non-steroidal anti-inflammatories don't work? I will tell you that we did a study to look at what people are doing in North America predominantly, but also in Europe. And it's really very, very different what people would do next after not having the non-steroidal work. But for most, I think they would go to either a TNF inhibitor or a bisphosphonate. And both of these help many. I would say that the evidence in the literature, case reports and case series would say they help most. So why were these tried? So they are blocking key pro-inflammatory proteins. So one of the earliest pro-inflammatory protein we could block was tumor necrosis factor. So now it's been 2 decades that we've had drugs available that block TNF or TNF inhibitors. And so if you know that TNF can make these osteoclasts super angry, then it makes a lot of sense to block TNF. There are also early cases where somebody would have Crohn's disease, which we already knew if you block TNF helped Crohn's disease, who also had CRMO. So they had Crohn's disease and CRMO. If you block TNF, both got better. And so that's also evidence that those helped. And what we found over time that when we use these anti-TNF blockers, you block the TNF from being able to get to the osteoclast and to other immune system cells, and then he's back to being his happy self, and he can work with Bob and be in equilibrium and harmony. So what do bisphosphonates do? So they bind to something that's in the osteoclast and basically inactivate it. So, you see the bisphosphonate coming, it's like, oh no, I'm toast. So he is now not able to chew and act to help the immune response keep going round and round. And so you block the cycle. This is not permanent. These guys are made from bone marrow cells. And so you'll make more, but it can help you block that cycle of inflammation. And I think for me, in my experience, bisphosphonates seem to be the fastest way to kind of have pain relief with people who have significant CRMO. We use both TNF inhibitors and bisphosphonates. And I have some people on interleukin-1 blockers, but that's a small minority. So why this approach? It's really based on experience and expert opinion. It is not based on well-controlled studies. In the United States, we do not have a single FDA-approved medication for CRMO. And that's true in other countries. We need controlled trials to determine which is better. What should we do? Should we take everyone who doesn't do okay on a non-steroidal and put them on a TNF first? Or should we take everybody and do a bisphosphonate first? Is there something about something else in their, how they look? Do they have Crohn's disease? Do they have psoriasis? Because those things can go together with CRMO, as many of you know. Then maybe the TNFs are better first. So we just have so much to know. We need to be able to test additional medications, not just the TNF inhibitors and bisphosphonates, in a controlled fashion. We need more basic science work, and we're working as hard as we can here in the lab. And there's several other investigators who are working on CRMO specifically, and then a lot of people who work just in the field of osteoimmunology, trying to better understand the immune system in bone. We do a lot of studies in blood cells, and we really need to study what's going on in the bone better. And there are some new tools available that we might be able to start using to do that. And then we need to understand the contribution of lifestyle choices, which I'll show you some slides in a minute, and lots of other things. This is just a partial list. So I get this question, what can I feed my child to make this go away? I get it for virtually almost anyone who comes in the rheumatology clinic, regardless of what's wrong with their child. But I get it a lot more in CRMO if they know about this mouse model that can be changed by changing diet. So we know that osteomyelitis in the CMO mouse can be protected by a diet change. But again, no human with CRMO has the CMO mouse mutation. And in our hands, we did several different types of fat, and the high fat, high cholesterol diet, which is the bad diet for cardiovascular disease, was the most protective. So I do not want anyone to go away and start eating a high fat, high cholesterol diet. No, no, no. That you're more likely to harm yourself than help yourself. So many foods, so what do you do? So many foods have been labeled inflammatory. Can you just avoid them? So there's lots of information on social media and on the web and in the press on anti-inflammatory diets. And so the question is, like, should I put my child on an anti-inflammatory diet? And my response to that is, like, they're very restrictive and they haven't been tested in children. So some anti-inflammatory diets make it so you can't eat gluten. So no gluten, no eggs, no dairy, no nightshades. So nightshades are those tomatoes and pepper family. And there's other things on the bad list. And so you end up with not having a lot of food choices left. And so some adults who try anti-inflammatory diets often will lose weight. Well, we don't want our children to poorly grow. So it's kind of not, I think, the best idea to just, try this in your kiddo without some really serious help from your physicians. What I tell people, so my diet advice is eat healthy meals and snacks, minimize added sugar, avoid processed foods, eat a lot of fruits and vegetables. Like that should be the main part of what you eat all the time. Eat lean meat if you eat meat at all. If you don't, that's fine too. But if you do, eat lean meat. And then eat fish. So there's lots of fish with really good fats in them, but you really need to watch the mercury content of the fish. So there are some fish that are high in mercury, and we don't want our kids eating a lot of that. Eat healthy fats like avocado and olive oil, and avoid the unhealthy fats. So saturated fat things like fat on some meat, butter is in that category, although I do like my butter. But it's all about balance. Eat whole grains and eat nuts. And really, if you look at what I just put there, that's kind of the basis of a Mediterranean diet. And the Mediterranean diet has been kind of consistently shown to improve health and longevity. So that's all I have to say. Thanks for listening. This is where I work at the Children's Hospital of the University of Iowa. It's the Stead Family Children's Hospital. This is our football stadium. And at the end of every first quarter at football, everyone in the stand, so 70,000 fans, turn around and wave at all the children who are in the hospital. And it's a very touching thing to see every time it happens. And then my acknowledgements, there's lots of people who have helped with what I presented, and including many people from all over, including Canadian folks. Paul Dancy, the Ron Laxer and McCollum McCurley, who we talked about, but really from all over the world. Thank you.
Thanks so much, Dr. Ferguson. That was an amazing journey to explain about what CRMO is and what we currently know about this disease. I'm going to turn now to Sheila, who is with us and going to talk to us for a few minutes about her family's journey with the diagnosis of CRMO.
Hi, good afternoon. Can you hear me?
Yes,
Yeah.
we can, Sheila. Go ahead.
That was quite something. It was very interesting to me. Where do I start? Well, it was 10 years ago. my youngest son was in kindergarten for the first year. They were doing full school, so he went down to one day having naps. It was an evening where we were just relaxing, watching cartoons, and he started crying, and he said he had a sore on his collar bone area, which I thought, oh, maybe he had a fall or something. To my surprise, there was a lump there, and I went, oh my goodness, how did that happen? And he didn't have the answer, so right away I made an appointment with our family physician. We got in right away the next day, and he was very alarmed, and he said, right away, you got to go for lab work. And he was concerned it was osteomyelitis at the time, and he wanted me to take him to the emergency department, which was about a half an hour away from where we live. We live on Vancouver Island. So we did that, and we had many, many tests for Nolan. It was very emotional for me and frightening, recalling. My husband was working away at the time. So we ended up doing about 3 days, actually, sleeping in a cot in Nanaimo at the hospital, and still no answers for quite some time. It was about the third day we got told that we were going to Vancouver, that we were going to see an orthopedic surgeon, in Children's Hospital, BC Children's Hospital. And so I had to navigate my way over there with Nolan. From there, we got referred to Dr. Laurie Tucker and the fabulous rheumatology team at BC Children's Hospital. And that's where our journey started, with many x-rays, bone scans, tests, blood work, etc. So it's been a long journey. And I must say, Nolan, through all that, he was such a little trooper. You know, he never complained, and he always had such spirit and humor with all what was going on. He was such a great guy. Then, lo and behold, we're into our treatments over the years. The first line of treatment didn't really go that well for Nolan, so we graduated to the bisulfate, permiginate infusion, and that really helped him, along with, physio and watching his diet and rest and things like that. So it was about 5 years ago, and my middle son, Blair, had an unexpected fall at the trampoline park at a birthday party and hurt his wrist. And I thought, oh, it was a fracture. So we go and get that checked in an x-ray and everything because it was very sore. And it also came back with a diagnosis of CRMO. And I thought at this time, how could this be? I thought it was a rare disease. I didn't think I would have two in one family kind of thing. But it happened, and we had another journey again with Blair, which his isn't as chronic as Nolan, I would say. Having said that, we do due diligence at home with trying to be active to help CRMO try to get our rest, the boys get their rest. We have changed our diets a little bit. We noticed sugar and additives affected their flare-ups. So we try and watch that. Although having said that, it's not a perfect world. We still like chocolate and grandma's pies and things like that. So kids have to be kids. So I think the basis is just eating healthy. I do start off the morning with a fruit smoothie and often put fresh vegetables in it. I incorporate fish oil in their diet. And, I try and stay away from the processed foods as much as possible. Again, it's not ideal, but we try. Exercise is a really big one. the CRMO has created different stresses in, the children's life or parents' life, including missed school days, especially for Nolan, some emotional stress. But we always get through it, and we count our blessings, and we think positive. And it's been pretty good lately, I must say, with the boys. Blair is graduating this year as we speak from high school, and I'm very happy for him. And he's also in transition to CRMO, so he's 18 now, and that means he's going to transition out of Children's Hospital, BC Children's Hospital, to an adult program, which we hope to locate a rheumatologist on the island here for him to see that that transition will go smoothly. I also teach the boys to advocate for themselves, to feel how they feel, to recognize symptoms, and to recognize possible triggers that might offset something. And they have the tools in their toolbox to do things and to help themselves. Having said that, I think CRMO has taught us a lot, and we count our blessings each and every day. We say our prayers, and I think a big thing is having humor. And I know that my boys will be very successful in their future, and CRMO won't hold them back from anything. They're very positive in whatever they want to do, and they've been very resilient. And that's about all I have to say. And thank you again, Dr. Tucker and the Rheumatology Department at BC Children's Hospital, and all the wonderful nurses and the physiotherapists. We're truly blessed. Thank you.
Thanks so much, Sheila, for coming on and sharing your family's story. It's really terrific to hear things from your perspective. And yes, I do remember that time many years ago with you and Nolan in the clinic room very well. We're going to go to the question and answer period. And we've had questions that were sent in ahead of time, and we also have quite a number of questions that people have been putting in the Q&A, so that's terrific. I want to just let people know that if your question isn't answered today on the live question and answer, we will try to answer it and put it up on the resource site later. So we'll try to get to all the questions and get the information out. And I think a lot of these questions probably are directed towards you, Dr. Ferguson, but we'll get started and we'll see how things go. So one of the first questions that somebody asked is, why is it so hard to diagnose CRMO? And I think Sheila touched on that a little bit.
Yeah, so it's a diagnostic odyssey for most people. And I think a lot of times it's either they think that you have an infection, because osteomyelitis is most often felt to be infectious, but I don't know that we have great data on that. I think we're rethinking that as well. Or cancer. And the biggest problem is there isn't a diagnostic test. So there's nothing in the blood that's specific that we can, if you get a certain answer, it's CRMO. And sometimes the tests are almost all normal. And so that sometimes leads people to getting sent out the door, especially if their primary care provider, if you've got a child with leg aches and pains and all their blood work looks normal, often this pain is worse at night. And so a lot of misdiagnosis is also for growing pains. So we don't have a diagnostic test. So that's the first problem. So people have to be, kind of have a higher index of suspicion, like that this seems out of proportion for what you'd think for growing pains. The other problem is sometimes the plain x-rays, which is the first sort of imaging people do, is just like a regular radiograph. those can be normal too. And so then it's super hard, right? You've got normal lab work, you've got a normal x-ray. So whole body MRI has been something that has really made a huge change in how fast this disease can be diagnosed. And it's not available everywhere. We're kind of on a crusade to try to improve that by writing more reports and talking at scientific meetings. And then for us in the United States, talking to medical directors at insurance companies. So problem, we don't have a test. That's one of the things that basic scientists are trying to find is there something, a ratio of finding these inflammatory cytokines in your blood that's different than other diseases. But we normally don't test for TNF levels or in the blood, and interleukin-1 levels aren't really detectable in the blood, even with interleukin-1 mediated diseases, because it tends to hang out locally by the cells that it's causing trouble with. So we just got issues. Yep, for sure.
Yeah. There are quite a number of questions that are around the issue of treatment of this disease, and several questions that relate to how long does treatment need to continue? Is it possible to discontinue treatment? And is there some risk of relapse if one does that?
Yeah, so this is also something that we don't have great information on. I think in general in medicine, we study how to put somebody on a drug, but we don't study how to take them off or when. And we're trying to address that now through different ways, like having a registry. So having a really good registry where we follow people with CRMO or whatever disease that you're interested in long-term over time. We have, what we're trying to do is try to get people at multiple different health care centers who are taking care of kids with CRMO to treat or to use the medications that you can use in the same way, not necessarily use the same medications. So it's called a comparative effectiveness trial. So if I tend to go to bisphosphonates before a TNF inhibitor, but my colleague somewhere else tends to do the opposite, it would be nice if we collected all the information about how that patient was doing and then could compare whose patients tend to do better. It's definitely not a controlled trial and not perfect, but without a lot of resources to fund clinical trials on specific drugs, it's one of the ways we could try to get to that answer. Bottom line, we don't know. What I do is I think of CRMO kind of like rebooting the computer. So when your computer gets to acting up, it kind of, maybe like Sheila's, gets into a thing where it won't quite do what you want it to do, right? So our immune system in CRMO is doing something we don't want it to do anymore. And it kind of just is, going in a circle and won't let you out of it. So the medicines I kind of think of as kind of like shutting down the computer, right? We're going to reboot the computer. We're going to leave it off for a while, see if it will go back to its happy place. So all your kids at one point had healthy bones, right? Can we get it to that happy place where Bob and the osteoclast guy are happy again? And then take it away and see if you can do okay off medicine. And we don't know what time period that is. If somebody's having lots of trouble with their CRMO, I try to get them to go 2 years. And that's just from the feel of other rheumatic diseases, which are also a kind of dysregulated immune system. But sometimes some kids will get one course of bisphosphonates and that's it. They don't need any more. We have a lot to learn. So we really do kind of, each doctor tries to do the best they can for what your child specifically is doing in individualized care.
Yeah, there's a whole lot of questions that relate to basically wanting to know what percentage of kids will continue to have problems with CRMO into adulthood, or does this disease resolve in some,
so
what percentage?
Okay, so I won't have what percentage? Sorry, it's another, kind of like answer we don't really know very well. And there's reasons for that. So there's lots of literature that people will look at long-term follow-up. So they will say somebody who's 5 or 10 years down the road, if I took all of my patients who have had disease for 5 to 10 years and then try to see who's having trouble, you can kind of get a percentage, right, for who's having trouble. The problem is when you look at these series of different places who do that, it can range from 0% having trouble to 100% having trouble. And the problem is with who actually are you assessing at 5 to 10 years? So if at 10 years, like if you start at 9, right? So you started at 9 years of age with your disease. At 10 years of follow-up, you're now 19. If you're doing well, the likelihood that you would come back and let me MRI you while you're at college having fun with your friends or, working and having your life is small compared to the person who is still sick and still has pain. They're going to come back at 10 years and they're going to let you MRI them. And so there's this bias to who you follow up at long periods of time that can change it to look like it's worse than it is. That would be the bias, is that it seems worse than it is. So all these numbers have to be taken, with that in account. Who are you following? How well are you following them? And so the problem is we don't have great longitudinal follow-up. And we lose people when they go to adult rheumatology. I saw, like your son is going to the adult rheumatologist. It's a scary time for parents because most adult rheumatologists don't see this. We're training people here so that I don't have to keep taking care of adults. I have some 60-year-olds. I'm like, okay, this is getting too old for my pediatrician body. But they don't see it. So either the kids are just going out and they're having trouble and they're not going to the doctor, or they're not having as much trouble into adulthood. And I think it's probably somewhere in between. So I see a lot of young adults who still have trouble. I would say most of my patients are not coming back when they're older teenagers and adults. And I don't have great follow-up for you to say that I'm confident that most of them don't have trouble because I see patients from all over the country and the world. So if they're doing well, they're not going to come back and see me. And some of them just can't afford to come back and see me. At some point, they fall off. Registries will help this. So if you're able to enroll in a registry, if somebody asks you to, I would encourage you to let your kiddos enroll in a registry so we can answer these questions better.
Great. I will put in just a comment from our perspective here in British Columbia, because we're the only pediatric rheumatology center in British Columbia. So we would see most of the kids with CRMO from the province now. And I would echo that our adult colleagues don't know anything about this disease. So we're actually doing an annual talk for them so that they know how to take on our patients. But I find that heartening because I think that likely means that a large percentage of our patients do go on to do okay, and they're not running around seeking care for this problem. And there's going to be a percentage of patients who do need to continue on treatment and need ongoing care, but equally in our practice, a considerable percentage of patients have resolution, and we would follow them till they're 18 and they don't require ongoing treatment or care. So I do think we need to study it further for sure, and get a better idea of this. One parent asked.
Can I say one more thing? We do have an adult rheumatology registry for adults with CRMO or SAPHO syndrome. Yes. So if people are interested in that, they can email me and I could pass it forward to Dr. Alex Leonard, who's a junior person who is, this is going to be his career interest. So.
Great. One of the questions related, can you have CRMO only in one site? Which is a great question because the name itself says multifocal. Can it only be in one site?
It can only be in one site, but that's the minority. I am kind of old, so I still use the old term, which is CRMO. I think the advantage to me of using CRMO is just that it makes you look for another site, which helps you establish diagnosis. So it's that multifocality. If the doctors keep thinking, is there another site, it's going to make the diagnosis faster. But yes, you can have it just in one site. The most common places to just be one site would be the jaw or the collarbone, in my experience, but it can be just one site somewhere else. Yes, but it's probably 20%, 10%. If you look with a whole body MRI, for most people, you're going to find something else, or if you follow them over time, they'll develop another site.
A couple of questions asking, can you have CRMO and ERA in the same person?
Yeah, so I think that we see a fair number of people who will have involvement of the sacroiliac joints and yet have bone inflammation elsewhere. And if it were just in those sites at the sacroiliac joints, these are two joints that join your pelvis to your backbone. So your tailbone and your pelvis where they meet, that joint can get inflamed. And when it does, it is called an axial spondyloarthropathy or ankylosing spondylitis in adults, or ERA in children. So yeah, you can have something that looks very much like an overlap. So I tend to treat those kids like they have CRMO if they have bone inflammation elsewhere, because oftentimes they don't need lifelong treatment like a lot of the ERAs and ankylosing spondylitis patients. The outlook for getting off medicines for that group is pretty low. So, and then over time, there are definitely reports in the literature, and I've seen people who kind of go on to look more and more and more like an ankylosing spondylitis or ERA. So it definitely raises my level of suspicion that I need to follow them for a longer period of time and make sure that their back is okay.
Great. There's a question for you, Sheila.
Yes.
And do you have any advice for how parents can support their kids in learning how to advocate for themselves?
Good question, Dr. Tucker. Well, I think they have to be responsible in owning their own. I look at it like, and I taught it boys, it's like they're their own unique little package, if you will. What one person needs in their life, maybe it'll be different for somebody else. So I just teach them that they have to be responsible. It can't always be on the parent, because at the end of the day, we all get older, and they need to advocate for themselves with regards to boundaries, with school, with exercises, sports, courses, friendships. And having said that too, I do have a question as well. As older children transpire into adult years and they enter relationships, and they want to have children of their own down the road, what does that maybe look like? Will that be genetically passed on most likely, or do we not really know?
Yeah, so very few people who have CRMO have children with CRMO. Like, there are some for sure, but it's a very minority. We collect DNA from lots of people who are willing and to be in our studies, and a lot of them will have multiple family members because they're the most interested. But the bulk of people aren't going to have, like, to have two boys involved. You've already kind of got a little bit of a skew that makes you a little more concerned that you've got something more genetic going on. So there's not going to be any way to definitively answer it. I went into rheumatology and into medicine because my family has like bad autoimmunity. My son has juvenile arthritis, one of them. I have rheumatoid arthritis. I had vasculitis as a child. So Like I went into this because I'm super duper personally interested. I can kind of speak a little bit from patient, parent, and then like I would never not want to have either of my children because I was concerned they might get one of these things that I had, which weren't great. We have good doctors and good treatments. And so I tell everybody like, yeah, they might, and you should be a little bit more aware, and your pediatrician should know your family history. But for most of these things, we can give a good quality of life if they're diagnosed early. And then if it does happen, you know, it's always nice to help the next generation, to try to get hooked up with a scientist who might be able to do something and learn something from your family. Yeah, but the likelihood is still, like if you take identical twins, which there aren't very many with CRMO, so that probably isn't going to give us great information. But for most rheumatic diseases, if you're an identical twin and you, the likelihood of your twin developing the same disease you do is usually, you know, in the 10 to 20% range. There's lots of environmental things that are affecting our ability to get these inflammatory diseases. Unless you've got a single gene disorder and then that's all off, it's 25% or 50%, depending on if it's recessive or dominant.
Okay, one additional question that came up, this is for Dr. Ferguson. You did talk about the fact that currently we really don't have any specific genetic mutation that identifies CRMO in most patients, but one parent was asking, is there currently a way to identify whether other family members are at risk?
Yeah, so no, until we know what those risk alleles are, we're not going to really be able to tell you. There is a higher risk of having Crohn's disease, so but we still don't know exactly how much those Crohn's disease risk alleles play a role. So yeah, I think genetics it's too early for prime time. Unfortunately, we're not quite there yet.
Right. There are so many questions here, and I really thank you both for answering the ones we've answered. And I'd like to assure people that there's so many great questions that we will we'll copy them all down, and then between ourselves and the Medical Advisory Committee of Cassie and Friends, we'll try to address most of these questions. If you've asked specific questions about your child's specific care, we may have to communicate with you in a different way, because I think that's probably we wouldn't be posting that information. But I want to thank everybody for all of this great engagement and the beginning of this conversation. We're going to wrap up now. This has been an amazing session, and I again want to thank Sheila and Dr. Ferguson for speaking today. And I want to let you know that the idea for this session was hatched by a new Canadian CRMO Pediatric Rheumatology group, which includes many of my colleagues from pediatric rheumatology centers across Canada. And one of our important goals of our new group is to increase education and awareness of CRMO and to engage patients and families in the development of research in CRMO and participate collaboratively with people like Dr. Ferguson and others. We came to Cassie and Friends to ask for their partnership on this journey, and I'm so delighted to see the amazing response to this first step, with so many of you joining this webinar from near and far. We hope to remain involved with you as we develop our research program as well. So stay tuned, because we will probably be getting back to those of you who are in Canada to ask for you to help out as we develop our programs. I recommend that you also keep in touch with Cassie and Friends for more news about upcoming events, new research, and patient and support activities. The amazing work that Cassie and Friends is able to do is fueled by financial support from families like yourselves and businesses. So donate if you're able to help us continue. If you're a Canadian viewer, please think about joining one of our Cassie and Friends run teams across Canada. You, your family, your friends, and relatives can either run or walk in person or virtually and fundraise to support the really critical work that Cassie and Friends does for families like yours. If you live in British Columbia, please join our Cassie and Friends team and come out, and I'll say hi to you there because many of our team members from the BC Children's Hospital will be there as well. So I think that's all we have for today. Once again, thank you everybody for joining. This was really a fantastic experience.